Okay. Well, it is 12:01, so we might as well get started so we have plenty of time for your questions. But thank you for joining me today. I'm Jerry Davis, the Vice President of Education for the California Academy of Family Physicians, and we are very excited to be able to offer this, this initiative, Primary Care and Emergency Medicine Residency Program Collaborative. And obviously you're all here because you got the RFA. We are excited that this is our second go around. I've invited actually Shelly Rodriguez and Mary Alice here with me, who ran our first collaborative, which was very similar. We're expanding it a bit this year to include emergency medicine, psychiatry as well. So we are hoping to get a lot of exciting, interesting applications. And this is a learning collaborative, and IPMA is the Interstate Postgraduate Medical Association, and Mary Alice is their executive director here today. So if you have any questions about that particular part of the grant, then she's going to chime in on that. And I think I'm just going to open it up to Q&A. We are recording this session because we will be posting it up on the website so that your colleagues who weren't able to join us today will benefit from your questions. We will also be posting each and every question up in the website in our FAQ section. So hopefully each of you can be checking back with that as well as time progresses. And I think we'll just use typically the standard Zoom protocol where you keep yourself muted unless you are speaking. We'd appreciate it. And I'm going to go ahead and let people maybe just, I don't know if you want to raise your hand either physically or by the screen, or just unmute and go ahead and start with the questions. You're all here for a question, I know that. Is that, oh, I heard. Said Shakir, you are unmuted. Does that mean you have a question?
No.
Oh, now you're muted. Okay.
I can ask a question.
Sure.
Maybe it will break the ice. Anyway, one of the questions I had, I noticed that there are some hospitals that have applied for more than one program at the hospital, and they received it last year. And the vast majority were just one program. And my question is, can you share with us at all, did they integrate these grants together so they were kind of collaborative, or were they standalone? Or, you know, I'm just curious on some of the dynamics on how it worked, and we're interested in doing it, but we're also want to kind of meet the, you know, kind of the collaborative on what you guys are kind of thinking of. Okay,
great. And since Shelly ran that last year, and we did have two different programs within the institution submit separate grants, but then we're collaboratively. I'm going to let you, Shelly.
Thanks, and happy to answer that question. We did have organizations who applied and worked together. We had organizations who applied and didn't realize their colleagues in the same university were applying. So, for example, there were 3 Kaiser Permanente residency programs in Northern California, 3 relatively new residency programs who got together before they applied to talk about how they might each take a piece of a project and work collaboratively. So those 3 organizations worked together as part of the entire collaboration of 28 programs, but the 3 of them worked together on their projects, each leading a particular part of that project. Little different collaboration. In San Diego, the family medicine residency program and the internal medicine residency program didn't realize each other were applying until the grant awards were given. And they then used that opportunity to build a new relationship and work together, sharing resources, sharing expertise. And while their projects were different, they developed a new way to work together within the UC San Diego organization. Similar things happened at UC Davis, where we had internal medicine, family medicine, and OB-GYN working together, sharing information, sharing barriers, sharing some of their successes with 3 different projects. So if you want to work together with another department or another residency program in your institution, I say go for it. Go for your individual pieces so that you each get pockets of support, financial support, but then work together on the projects.
Yeah, and this is a large part of this is a learning collaborative where you're not just collaborating, you know, in your case, you asked about within an institution, but within all of the residency programs that receive grants. We will be, and IPMA will be taking a lead, Shelley will be doing a lot of the education, but we will be sharing best practices among everyone, no matter what your project is. So there will be a lot of communication back and forth, and really a lot of information on practice transformation and giving you tools and resources to do what you propose to do. Giving you as many resources as we can to make sure you're successful in that project.
Did that answer the question for you?
Yeah, no, absolutely. That was it. Thank you.
Great, great. Okay, we have a lot of quiet people here.
I'm Dr. Chris Kerrigan. I wonder if I could ask a question real fast.
Absolutely.
I'm new to this. I just moved to Ventura a few months ago and started a brand new addiction medicine program.
Yes, we chatted. Thank you.
Oh, that's right. Yeah. So I'm a teaching faculty for the internal medicine and family practice and psych residencies. And I got asked to spearhead a program, and I'm happy to do it, and try and involve all three. One of the residencies is very interested, one is somewhat interested, and one has a lot of reservations because they don't want anything to do with substance use disorder, unfortunately.
Oh.
So, it's part of the work in this field. So I think they'll come around eventually, but I can just do it through two of the residencies, right? I don't need, it doesn't have to.
Absolutely. You could do it through one of the residencies.
One of them. So internal medicine or psych is okay to apply through that and just use it.
Absolutely. Yeah,
okay.
Absolutely.
Good. My other question was, I was trying to look at guidelines.
By the way, you can also, I want to make it clear, you can apply from 3 programs within one institution individually for each grant, knowing that you will collaborate or whatever, but you can also do it as a group or individual.
Okay. If you worked on one project together, could you do 2 grants from 2?
Yes,
so we could do
it doubles your money, so, right.
Okay, yeah. So we could do psych and internal medicine, say we're going to work on one program from different aspects?
Yeah,
yes.
Yeah. So each of you would apply and you would reference each other in your applications.
Okay, good. And then my other question was, I was trying to look at specifics for project guidelines, and it seems to be pretty loose. There's not a lot of, I mean, our goal is the same. But it seems to be not a lot of, you just design a project and these are my goals, and there's not a lot of.
Yeah, I mean, we recognize that each and every one of your programs are unique. And so what we want each of you to do is think long and hard how you can come up with some creative ideas. You have this opportunity and potential funding to do some pie in the sky wishful thinking and figure out how you can best serve those patients and meet the goals that are identified in the RFA. We've had applicants ask about whether they can expand the physical facility in a rural clinic, for example, and will the funds cover that expansion? Yes, it could potentially. And same with supporting FTE or additional positions. It's absolutely most anything and everything is on the table for us to support, as long as it meets the goals and objectives and it zeroes in on improving patient care in this area. Yeah.
Okay, so if it was purely educational to improve physician education to get people more comfortable with seeing this population, would that fall under the umbrella?
Well, in theory, I hope you're doing the education for a reason, and that would be to improve your patient care. So absolutely.
Yeah, for sure. I have to sell this to some program director that want to make it clear we're not advertising more substance use disorder patients in their clinic. Yes. I don't mind in my clinic, but you always have to walk that tightrope where I say, no, I'm just prepping your residents because when they get out of residency, it's what they're going to see. So you can shield them all they want, but for the future.
Right. Okay, and they may not end up in their next job serving in that clinic. So they do need to have this education.
Yeah, I agree. And that's what I try and tell program directors is that when people leave, they see addiction and pain. that's what you're going to treat when you get out. And if you don't get into residency, you're going to be in over your head. So,
So absolutely.
Well, thank you for the questions.
Thank you.
And good luck in the new position.
All right, thank you.
Well, you've got a great team to work with down there, so.
Yeah.
Others that we can answer questions for you. I think a big part of this project is the integration of practice and program transformation. In the first program, we did maintenance of certification and some transformation, but we're building a stronger piece in this one. And so if you have questions about that, Mary from IPMA is on the line and quite able to answer those. I think the benefit of having a maintenance of certification as one of the vehicles for your residents and faculty members is a really nice added carrot. But if you have questions about practice or program transformation, now's your time. Now's your chance, because Mary's on the line.
That's the question. It's Teresa from Harbor UCLA. Are we able to, let's say, work on the inpatient side, not just the outpatient? Because our outpatient seems to be okay. We already have it set up. But can we work on the inpatient arena?
Of course. Yes, I mean, again, any patients that you are improving their lives is the goal of this
project,
for sure.
Okay, no, I'm just saying because there's like 4 different residencies, but we all on the inpatient side. Okay.
Yeah, absolutely.
I have a question.
Yes,
we have one family medicine residency program, but we have 2 rural tracks associated with it. So we have 3 sites. Or is it okay if we apply 3 different times? Because I can think of 3 projects that would fit the city versus a rural setting. Can we apply for a different project for each of our sites, even though it's one program?
Yep, absolutely. I mean, all of the applications will be judged by the same, rubric and criteria, whether you submit one for one track, one rural site and another one. We're happy to take anything and everything.
Thank you.
Mm-hmm.
Does that include a separate, say, street medicine outreach program? So it's not another necessarily clinic site per se. Well, I guess you could call it a clinic site, but like one for, say, our outpatient clinic and then one for our street medicine outreach. Yeah,
absolutely. Again, that's another creative way to reach patients where they're at. Certainly, we're happy to review all those applications.
Yeah. I think one of the beauties of this opportunity is that creativity and innovation is stressed. It's not the usual type of grant that you get where it's research-based or the like. So it really is a chance to do something very different.
And the opportunity to get a lot of great education and tools and resources to help you along the way, for sure. Well, I know you guys are not being shy here, but do we want to talk a little bit about the education? I don't know. This is an FAQ for you about the RFA, and really, you're going to be judged on the criteria outlined. It's very black and white in the RFA. So again, feel free to submit as many applications as you want, as long as, again, you're meeting those goals and objectives. So we have a rubric, we have a great faculty advisory team that'll be meeting and going over all of the applications. And then one thing new this year is the Department of Health Services, before we can award the grants, wants to actually look at who we have recommended and give us their blessing before they let us release the information. So there is a little bit of a longer lag than there was last time to get the information about whether or not you received the grant. But we're looking at your particular goals and objectives that you submit to us. Hopefully there's SMART goals, which we talked a lot about. It's nice to have measurable goals. We're looking at the target audience alignment, and we're looking at, the design and methodology you use to reach your goals and objectives, and then basically your organizational capacity. So that's kind of how we're judging this. And again, like my colleague Shelley said, this is an opportunity to use those funds in some creative ways that we are not putting a lot of restrictions on. We do limit overhead to 10%. So if you're in an academic institution, I'm sure you have to run that by them, but that's really the only limitation that we have per se on the funding. And we will, you know, as you know, and it said in the RFA, we're requiring reporting. We'll certainly have milestones in all the LOAs that we put together and check-ins along the way. And of course, again, this great opportunity for practice transformation information and MOC module. If you'd like to take advantage of it, and we're stressing that we really do through this learning collaborative among, and you'll learn from all of your colleagues through the experience as well. So we hope you spread the word, even though you're in theory competing with them. I hope you do, you know, let everyone know this exists out there. So,
Jerry, one other question. I know, you know, they, you know, one of the emphasis on what you sent out was, you know, the thing about that you're not doing it alone. You're, you know, it's kind of a learning collaborative, which is what you just mentioned. I'm just wondering, and I know you guys have it going on right now. Is there a website? Maybe I haven't seen it. I need to dig deeper, that we can look at some of the kind of things that are coming out from this year that we could potentially integrate in with what we're trying to do locally. So I'm imagining personally that, you know, obviously we're going to do stuff locally, but I'm hoping that we can integrate what you're doing nationally already. And, you know, I'm not a family physician. I'm an emergency physician. We're working with our family medicine residency director, but I just want to learn as much about what you're doing as a non-family physician, just so I can integrate it locally and nationally and kind of try to tie those in together. Any thoughts or recommendations you might have, you know, we can try to do, you know, in our proposal, both kind of a pie in the sky as well as what we're going to actually deliver.
Yeah, and I'm in the midst of putting together all the reports from the 28 programs that finished their work. Some of them had to get extensions because of COVID, like the rest of our lives. And those will be ready very soon. Mary, do you want to talk a little bit about what some of the programs worked on? Because you have a really close tie to some of the projects that they worked on in their improvement processes. And I think that would be helpful.
Yeah, just briefly, we added a quality improvement component to the first grant, which gave the residencies a chance to think specifically about the processes they used for implementing change within their organizations. So for most of the organizations, they were looking at increasing the number of both residents and faculty who were ex-waivered, and recognizing in doing that, it seems so easy both to do the education, but then as I believe Dr. Miller pointed out, actually doing it in practice is an entirely different thing than just getting educated about it. So we looked at what are best practices that are being used by other organizations, brought that to the table, looked at using quality improvement tools, looked at system change and how you, if you will, get to yes with a different department who may have a different objective, and how do you bring those tools into the residencies themselves. We looked at communications patterns that happened and how those became either accelerants or barriers to change. And then also encouraged folks to look at how they were going to create a sustainable program so that this wasn't just about training a group of residents or a faculty, but how is it that you start off so that next year, the following year, whatever you've done becomes standard of care? Who is going to be in charge? Who is going to start tracking those patients? What are those mechanisms? How might we room a patient? And so that we're thinking about way, way more than just the education that might go on with how do you provide guideline care, but what are the best practices and how you implement that within an organization. And particularly several of you have commented about working together between family medicine and internal medicine residency, adding psych, and those are organizations with perhaps different cultures, different measurement systems. And so we really are trying to give the tools and resources to folks to think through that in a thoughtful way, to gather data in a consistent way, and be able to bring that forward. So many of our tools and resources really focus around that. Process mapping, root cause analysis, system change, sustainability, spread and sustainability plans. So it's way more than implementing a specific program that you've got, and very much around how do we create change for generations. Hopefully that helps. It was exciting. We had a great time with the residents. Many of them said, wow, I wish I'd have known this or had this sort of systemness conversation earlier, because it very much says, yeah, this is about more than just getting X-waivered. It's about making sure I've got the systems in place to support care for these patients within my residency. So happy to answer any questions, but looking forward to working with you all and hopefully being able to do some quality improvement coaching and system change within your organizations.
Yeah, I mean, our goal is to see our grantees succeed, and we will, provide as many resources that we're able to make sure that happens. And we have a great team, that's, as Mary was saying, as Shelley was saying, it's experienced in already working in these areas, and hope that a lot of your new ideas and creative ideas, add to our already existing toolbox of resources to help folks. So. I was going to go over, so one of the deadlines that's impacted by the fact that we will not be able to announce the grantees until April is the fact that on April 17th, we hope to be able to notify grants by the 12th. That's giving DHS the most amount of time they asked for. So hopefully we'll be announcing grants before April 12th. But in the event they do take every single minute to do that and give us approval, we will be announcing it on the 12th, announcing the grantees. And in order to meet the timelines and actually roll up our sleeves and get moving, we're going to go ahead and keep our all-day Saturday meeting that we've scheduled on April 17th. It's obviously a virtual meeting that'll be a project launch and involve all the residency programs. So as you apply for this grant, just make sure you've got some folks on tap to be able to give up a Saturday in April to hit the ground running for sure. And last year, when we started this project, we had a lot of ideas that we would have face-to-face meetings. And as all of us know, COVID has made this wonderful Zoom environment much more, we're all much better Zoomists these days. And while we will continue virtually, certainly education and collaboration and mentorship and everything, when and if it is safe towards the end of our project, we'd love to get together in person and do an in-person meeting and maybe graduation or commencement program. So. And of course, we all don't know about the X-waiver, federal X-waiver requirements right now that we heard were, going to be going to go away, but now oops, that was an accident. They are actually not at the moment going away. So, from your perspective, I guess, we won't really know whether or not that training is required or not, but.
Well, and if we learned anything in the first group, and Mary can confirm this, it's getting folks X-waivered was not the problem. Having a system of support for those who have the waiver to provide the care is the issue. And I know all of you who are in practice seeing these patients understand that, so.
Right. But at the moment, we still need to make sure we have people X-waivered.
Jerry?
Yes.
Hate to ask another question since
that's okay. No one else is
so quiet.
I'm glad you're asking.
Yeah. So it says with the broad goal in mind, we have selected 3 objectives for this RFA. Would you like all 3 to be part of this, or would your preference be just one of the three?
Well, our preference is for you to meet all the objectives, if you could, certainly.
But it's not required.
But it's not required. And again, you're judged on, you know, how well and how creative and how much change and impact do you think your proposal is going to make, for sure. I mean, we want you to be realistic. So if it's not realistic, the way or the program that you're suggesting in your application, if it's not realistic for you to meet all three goals, then we want you to, you know, to not try and do something that is not realistic, you know, and not capable of meeting them all.
I think we'd rather you do one really well than three not so well.
Absolutely.
Which is what I think you all want as well.
I mean, I think improving the experience of patients is going to be, I would hope, an overriding goal for all of you and all of your work. So even though that's listed as a goal, we certainly hope that is part of everyone's project. And we try not to make the whole process arduous. I mean, it's hopefully one of the easier RFAs you've had to reply to if you've applied for a lot of them. If you've looked at our budget template, we're very you know, it's a pretty simple budget template. You can use your own budget template, whatever you like. And the new thing this year that we didn't have as a requirement last year is a reporting requirement that DHS has included this year. So I did go ahead and put that in the announcement, and the RFA is just what those numbers and what data that Department of Healthcare Services is going to ask us to report each month. So we, of course, need you to report that. A lot of cases, it'll be zeros across the board if you're not addressing those certain elements in your RFA. So by sending that data document, I didn't mean to imply that you should be addressing all of those things. I just wanted to let programs know that that is the questions that we will be asked as an organization to report on to them, how each of our grantees are reaching, you know, we have to accumulate all those numbers from each of our grantees. Just wanted to clarify that as well. I think we will be publishing something from our cohort 1 as well. I'm not sure, like Shelley said, obviously COVID disrupted many of our lives, and certainly those of our program grantees from last year. So we do have some extensions going on, but I think that'll be a great, you know, great piece of information for everyone when we do get that out there to the public. Yes, yeah, you know what? You've got the floor.
Okay, so objective number 1 says advance the training of primary care residents and physicians. So although I'm an emergency physician, I consider myself doing a lot of primary care and emergency medicine. Yep. A lot of people don't consider us primary care for right reasons. So I just want to make sure from the grant perspective, when I read above, we are part of that primary care. So
absolutely,
we don't need to improve the per se, although we're going to collaborate with family medicine, we don't need to directly improve the care of family medicine residents. As long as I know emergency medicine residents, that's okay.
Absolutely, and I guess that is kind of a question mark because we are the California Academy of Family Physicians running this collaborative. But no, there is no requirement that family medicine is included in any or all the proposals at all. You know, we've expanded it to psychiatry this year and emergency medicine, as you know, so we want those organizations to be submitting applications and doing good work, because you certainly are touching all of these patients as well as the family physicians and
more now during COVID than ever before.
Right.
You know, they come to the emergency room for all kinds of primary care stuff that we would have never touched before, but we're doing more than ever before.
For
the sake of this project, primary care is a fairly broad definition.
Yes. Yeah, in fact, we were toying, how do we change the name? We're expanding it to psychiatry, emergency medicine, but yeah, it's kind of hard. It got long enough as it was. We just kept it at California Primary Care and Emergency Medicine Collaborative. let's see, trying to look at the RFA to see if you have anyone. So you did see the, you know that the awards are not to exceed 63,000. I think last year we did in fact award all of the grants were at the maximum amount. Just FYI. We do have, I did want to mention, so if you are interested, and I assume you're on this FAQ, we do have that link in the RFA that we would love you to go ahead and go to that Survey Gizmo document and just put your residency program down that you are interested in the program. It gives us a better idea of how much more advertising we need to do to get the word out, because we do want to be able to offer this to, we do want to spend the Department of Healthcare's money, we'll put it that way. So we would like to know how many are interested before February 12th, which is 11 days.
It doesn't obligate you, but it gives us a kind of a head count.
Right, absolutely.
I was wondering if I could ask one more question.
Of course.
You said up to 10% can be used for overhead. Sorry, I'm new to this. Can you define overhead for me?
You know, we put that in because many universities charge indirects to people who get grants in the range of 35 to 42%. Okay. And we wanted to get as much money in your project's pocket as possible and not in administrative pockets. So we put a limit of 10% for those types of indirect overheads so that we get money in your pocket to do the work.
Yeah, and you can see by the budget template, we don't expect you to be breaking down your expenses by, you know, telephone or lighting or electricity or anything like that.
Okay, I gotcha. And so somebody I was just asking, we did an education project and I wanted to get different specialists to review it and pay them for an hour to review
it. Absolutely. Absolutely. Really, that, like Shelley said, that was put in there because of the, you know, a lot of the university's requirements that they get a piece of the pie. And we wanted to just make sure that piece of the pie was limited so that most of the money went directly to the program.
All right, great. Thank you.
Sure. Absolutely. See, I answered all your questions in the RFA so well, you don't have any more. Also, of course, my email address is there. So if things pop up that you think of later, you certainly can reach out to me and I'll be happy to answer those via email, or you can give me a call as well. So I don't feel compelled to stay on this line. If you're done answering questions, this recording, like I said, will be up on the website. Not that any of you need to look at it for a second time, but for those of your colleagues that weren't able to join us. And again, like I said, we will be putting together an FAQ, supplementing the FAQ, I should say, document that's already up on the website, which is in the RFA as well. I would link to it in the chat room, but you have it in the RFA, so. So unless I'm giving you a last chance to ask questions, I haven't heard from a few people, but hopefully you got a benefit of some of your colleagues' questions coming up. So thank you for joining us. And again, we're certainly accessible. My email is plastered everywhere, my phone number, you can go on the website, and we look forward to seeing your application soon. Okay, bye-bye everyone.
Like, 20 minutes before it started from my program director. So I didn't have a chance to look over everything. I was just looking. So it sounds like there is an opportunity, like let's say we were given some grant money for some advisorship and some mentorship. I was just listening to Mary Alice, How does that work? And I was looking at the expert advisory panel at the last page here. Would we just reach out or something, or do you reach out before you turn in the grant application, or how does that work?
So that education will be taking place after the grants are awarded as part of this entire learning collaborative process for our grantees.
Great.
So Alexa, this is Mary. The way we've designed this grant is that we actually will be doing individual coaching with each of the programs, assuming you want it, bringing together a quality improvement person, looking at your grant and trying to understand what we can do to be helpful to you. So you don't need to build that in. It's really a component of the grant. And then also we'll be putting together education materials that you could share within. But we found in the first grant that each change is local. And so what may happen in your organization may look different than what's happening in someone else's. And we wanted to make sure that we could work with you and support you in change in whatever way possible. So you don't need to, it's not only do you get the money, you get that personalized coaching. So.
Oh, that's great. Okay. That's awesome. Okay, great. Thank you. I really appreciate your help today. I took a lot of notes. So thank you.
Absolutely. We'll look forward to hearing back from you guys.
All right.